Good morning or good afternoon or good evening, wherever you are in the world. Welcome back to another episode from Straight from the Hip with me, Callum East. I've got Benoit Matthew here, as always, the dynamic duo.
Okay.
How are you going, Benoit? How have you been?
Yeah, it's good. We're just talking off the screen. There's a lot of bit of bugs going on and the change of season as well. So I think it's sort of a normal thing, especially working in a hospital setting. We are not immune to this, isn't it? We see a lot of patients, so we can't just hide away in a little work from home, isn't it?
No, we are human. We are still human and we get sick. Like doctors that never get sick. We all get sick.
But the important thing is we're here. We're still here, and we made the effort to be here. And we're just touched by all the feedback which you guys have given us, and it's great to see. And we got some exciting plans for you guys. Is one of the things which people ask us is there's a lot of information and it's hard to write it down. Obviously, we got AI and other benefits here, so we have created, along with our input, we have created sort of booklets. The first booklet which we'll be publishing is on FA syndrome. It's taken from the first episode or second, so it's more like for people to use like a clinical resource, especially they can use it for the in-services, and it makes it more usable, isn't it? What do you think?
100%, and I've had a bit of a peek at it, and it does look awesome. So we hope this will be a fantastic free resource for everyone. It will come out soon.
Yes.
I want to extend my personal thanks. I was telling Benoit this week, I've had a message from a couple of physios in Poland. I've had a couple of Spanish physios that messaged me, and there's a couple from the UK as well. This is all on Instagram or LinkedIn. And Benoit, I know you're the same. We're always happy to receive messages, feedback, questions, etc. But it's all been very positive feedback, so we really appreciate it. Certainly, it encourages and motivates us to keep doing this project.
Yeah, definitely.
So yeah,
and also let us know what further things you want from us, because we can always tailor it based on your needs. So obviously, we got a lot of things we want to cover through, but we are always interested to know what you find challenging in the clinic, and we can always explore those things in detail. Excellent. So we got quite a few things today, Callum.
Yeah, this is the bit you're excited about, Benoit. I can tell you're itching to get going, because this is where we're talking about the different management options for FAI. So we've covered a lot on the subjective, the clinical assessment, the imaging, etc. Now we're talking about management options. So I know we're covering briefly conservative, because we have touched on that quite a lot more detail in a previous episode. I know we're going through injections, we're going through surgical decision-making. That's kind of what we're summarized covering today, isn't it, Benoit? So conservative, we know that this is typically documented as this has got to be the first line management.
Yes. Yeah.
How would you bracket this? If you were going to say to someone comes in and says, Benoit, how do you go about conservative management? Have you got a framework? Are there phases? How would you go about conservative options?
I think it's setting the scene. Is one of the things as patients come in is everybody wants to know their options. So as you said, everything falls into these three buckets. So conservative, which I think it's the gold standard initially, because it's safe, it's not invasive, and we don't want to rush into surgery, especially in a flare-up, because people in a flare-up think they want surgery tomorrow, but then you ask them in 1 month time, they're fine. So sometimes we see people in a bad phase and people want desperate options. So I explain to them, like, these are the three buckets here. And one of the things I always try to sell conservative is, let's say conservative doesn't work and in 3 months you're not happy with that, but you will definitely be stronger and more fitter even if you're going for surgery. So in my opinion, conservative management is never a waste of time. It might not necessarily prevent surgeries in some cases, but it's a good place to start because your baseline will always be better than that. But having said that, so there's a bit of misconceptions on conservative. The first thing is I try to make it very clear, is the timelines. So people expect a big effect. So we know from the research, this is a very important point, which I think I make it very clear on day one, is you're only going to see effect in your symptoms usually around the 4 or 6 weeks mark. You will have change in your function pretty quickly within 2-3 weeks. But there's no point asking me every week, my pain is not better. That's not going to help anyone, really. I don't really ask people for the first month, are you better? I only ask them, did you have a flare-up? So that's really important, because it creates this negative energy, because if the patient is coming every week and 3-4 weeks, you're not seeing any difference, you also feel a bit bad about it. So I think it's really important to let patients know that the changes in pain is a bit slower, and you're looking at timelines of at least 4 to 6 weeks, more likely 6 weeks. And we know from the evidence, I think there's a lot of been systematic review done on this. The minimum timelines commitment is 3 months. So 3 months is the bare minimum. So you will have significant improvement in your pain and function. But 3 months is not the timelines for return to sport. So if you want to get back to like for a half marathon or get back to football or hockey or something, you're really looking at 6 months, because the end stage rehab, the plyometric phase, the return to running, the change of direction training, the sprinting stuff, that will take from 3 to 6 months. So you're looking at a solid 6 months really here before you have a real meaningful difference. So a lot of times patients are a bit shocked when I go through this, and they can't believe that it's such a long. They think it'll be fine in 3-4 weeks, and so it's a bit disappointing. But it's being very important and honest, and they have to buy in that whole. There's no point you and me talking about the rehab if the patient doesn't buy the timelines. So this is very important to set the scene. But I also put a bit of carrot in front and say, like, for example, in 4 to 6 weeks you're not improving and you're still in a lot of pain, we can look into other options like injections, other thing which we'll discuss shortly, because people also want to know what's plan B. So if things don't improve, what are the other options? So that's the first thing, which is the timelines. The second point is, we know with any chronic conditions like hip OA, knee OA, or any chronic condition, you're going to have flare-ups. So flare-ups is part and parcel of any rehab. So you might have a crappy week, but just reduce your load, maybe take 2-3 days of some anti-inflammatory, get into the pool, reduce your sitting, stop your weight training, get into the pool, and things like that. So you always give them a rescue plan. So if it flares up, nothing to panic. It's just normal thing. Just calm it down. Don't think it's going to set you back by everything. It's just a temporary blip. So I think those two things you have to really hammer home: the timelines and also expecting flare-ups. I've never had even one patient where they not had at least 1 or 2 flare-ups in that 6 months. So I'm expecting that to happen. I don't want it to happen, but that is more likely to happen. So what you would say on that, Callum?
Completely agree. This all comes down to, so in my clinical notes, anyone that reads my notes, they will see ideas, concerns, expectations as an acronym. And that is all about setting those scenes, managing those expectations. The one thing that we know from this isn't just hips, this is musculoskeletal practice, is that if we can help build self-efficacy in a patient, then their outcomes are likely to be much, much higher. We know patients that have got a higher self-efficacy in musculoskeletal pain, they will get better, a bit more efficiently. I won't say quicker, but efficiently. So setting those expectations can help with that. Because you're right. Look, it depends on who's coming through your door. If I've got 70-year-old that's coming and we're talking arthritic hip and they just want to be able to walk their dog, okay, 3 months, that's a fair expectation that we should be able to do that in 3 months. If I've got a 25-year-old hockey player, which I was saying to you, Benoit, off camera, hockey is massive in Western Australia. I had no idea. But if I've got a 25-year-old lad that's wanting to return to hockey and it's in his off season, 3 months is just to probably get him back to a relative level of baseline training. We then need to tag on at least 3, maybe even 4 months to really go through strength related training, whether we're going into power and then plyometric work, return to sport. So setting those expectations is incredibly important, and making sure people are aware that they will encounter flare-ups. It's not even an if. I'm a bit like you, Benoit. Even last week, I had a couple of flare-up hips. They didn't do anything wrong. It just happens. Life happens. They need to know that going into it, because we want to try and keep their self-efficacy high enough. We want to empower them high enough and really buy into the plan. And yeah, sure, look, we're going to talk about injections. If we need to lean on injections, we need to lean on injections. Doesn't mean you failed. Doesn't mean they failed. It's just sometimes rehab doesn't work. And that's okay. Yeah. There are other options available to us.
Yeah. And I think that sets a scene on to the different phases here. So once they buy in the timelines, so people like to have, it's like sometimes selling like a story, like a narrative. So I say them like, you have these 3 phases here. The first phase is what I call calming the hip. You got a very sore hip, irritable hip. And I think you've done in your previous episodes, you've gone through all the things do and don'ts not to do. So don't piss it off, don't ram it into end range flexion. Don't push into all your hip mobility drills. Increase the seat, and get into low impact stuff. So sometimes a short course of 1 or 2 weeks of anti-inflammatory like naproxen along with the GPs, fantastic idea. Reducing your steps. So these are sensible things. So there's no point ramming into the strength phase unless your symptoms are really controlled. So we don't have to make it too complicated. So I just look for a few things. Can you sit for at least 20-30 minutes? Do you not have night pain? Can you walk for at least 20-30 minutes? How is your pain during the day? You don't have night pain. So those are basic markers we want to achieve in phase 1. So I think the biggest mistake I see, especially when I get failed patients, is people go too hard on the strength phase when the symptoms are not controlled. So you have to control the pain and then make them a bit more bearable. And once you build up the calming the hip, then we can go to the next phase, which is building up your capacity. So where we are trying to improve your strength control, working on the key muscles. So I generally start with the hip abductors, hip extensors, the hip external rotators, and definitely a bit of trunk work and kinetic chain. I try to avoid pushing into hip adduction and hip flexion at this phase because they can be quite provocative. So start with the areas where you know it's not going to irritate them. Build up. So this is where the physio side is really good. This is where we're comfortable with. So building up that sort of local strength, resilience, and this is the phase. I also try to get them back into the gym very quickly. So right from the beginning, I say to them is if we want this to work well, obviously it's a partnership. It's 50-50. I'll guide you and I'll help you, but you'll have to also help yourself. So one is to not to really make it worse by avoiding the things which irritate it. Number two is doing the home-based, the physio stuff. And the third is most important. You can't really rehab an FA patient, in my opinion. I'm open to your opinion on that. You can't really do this without a rehab at the gym program. You must be going to the gym at least 3 or 4 times. We're not talking about an elderly or a hip. You must have access to the gym. You don't have to go every day, but most people, the sweet spot is 3 or 4 times a week, because to create the load and to get back to high level sports, it's pretty much difficult to do just with some band exercises or the gym ball curls at home or some crab walks. That's not going to really cut it for getting them back. So they get an idea of these 3 phases, and the final phase is the most exciting phase, is the return to run or return to sports. So we'll have a graded return to running program. We can look at the gait analysis, and also going back to, this is as you're saying, like the hockey, making it more sports specific. So you might have some drills which is sports specific. Obviously, there's also other adjuncts which you can throw in here. So you might do some hands-on treatment here, soft tissue techniques. Some people use dry needling. I have no issues with that. If you find that useful. Some people use radial shockwave for muscles. So whichever tools you have to help that rehab journey, because obviously these are adjuncts. They are not going to replace that. They do have a role. But this is sort of the general 3 phases. And roughly, you're talking about each phase can be anywhere from 3 to 4 weeks. Sometimes it can be 6 weeks. And that comes nicely to 3 to 4 months. So at least they have a map. And the last tip I would say on the conservative here is try to give people some personalized benchmark for each phase. So they know that they have achieved each phase. So you could have a benchmark for phase 1. And this could be tailored to them. It could be simple things like handle dynamometer. It could be a simple sit to stand. It could be a singular hop test. So try to give them some markers, because they know that they've achieved. Otherwise, it becomes all blurred. They really don't know where they are. They need to know, like, it's like, I don't know, when you go in Eurostar or on any train, they say, if you're going to Amsterdam, they say, oh, you arrived in Belgium. You arrived in Live, you arrived in France. You need to tell people that you arrived, I don't really care whether I, there, but they need to know that you are on the journey. So there's no point me just knowing where I am, so people need to know where they are in that process. So it's up to us to show them that you're improved by that, because otherwise it looks like a bit of a mushed up experience.
Yeah, agreed. So the only sort of other bit that I would add into the mix is psychological readiness as well.
Of course,
so this is where I think the surgeons that I work with here in Perth, we use the 𝐓𝐡𝐫𝐞-12 or the modified Harris hip score. But there's loads out there. There's the 𝐏𝐸𝐺𝑠, the 𝐏𝐸𝐺𝑠. You use whatever outcome measure that you are familiar with and your surgeons are familiar with. If I'm putting someone through a training program, so I've got I think 3 at the moment, high-level hockey players. So we put them through a 4-week cycle, a 4-week mesocycle of training. So at the end of those 4 weeks, I'm gonna resend them that questionnaire again that they complete in their own time, because that is another really nice way for them to see how confident they're feeling, how able they're feeling from a mental perspective, as well as you said, Benoit, the physical stuff. If you've got dynos, if you've got a force frame, great. If you don't have any of that and all you do is a bridge endurance test or a single leg squat endurance test, whatever it is, just find something that you standardize based on what you've got available and you just repeat it. And 100% agree with that. Yeah.
Yeah. So I think that goes nicely to the next phase, is the injection option. So I think injection sometimes can be a dirty word within the physio world. They think, oh, that you're giving up. So I used to think for a long time, if I'm referring patient for injection, it's a bit of that I'm not done my job well. So I used to think that for especially early part of my career. And I think, I've moved on from that. That's why one of the reasons I went into learning injection therapy is it can be extremely useful as an adjunct when people are really not going anywhere with pain. So I think we can put that into 4 types of injection or categories here. The first and possibly the most important one, which I use a lot in my NHS advanced practice role, is diagnostic. So this can be very tricky. So this is very important to give a context here. I'm seeing patients who come to me after 2-3 years of pain. They've done a lot of rehab and they got a very mixed picture. They, in a bit of sensitization, they are having buttock pain, they are having back pain, they have groin pain, they have a bit of clicking, and the MRI shows obviously impingement, the back shows issues. The biggest issue we have with hip is which is the source of pain. So one of the best option we have is diagnostic hip injection. So we're talking about local anesthetic here. It has to be given either ultrasound guided or fluoroscopy, and we're looking for an effect in pain. And there's a recent studies have shown you want an effect for at least 50% improvement, but that can be only be 2 days, 3 days, or even 3 weeks. I'm not more interested in the timelines. I'm more interested in the effect. So if a patient comes in, you give them a diagnostic injection and the pain is 50 or 60% better, and they feel that the hip is less sore, then you can say with confidence that there's the generator is from the hip joint. If not, then you might really be cautious before referring on to surgery. So all the top surgeons I work with generally tend to do, especially for the complex cases, they'll always try to do a diagnostic injection. So that's the first one. The second one is looking into in a bad flare-up. So you have a patient who's really struggling, bit of labral involvement, night pain, limping, catching, can't sit for 15 minutes. You've tried all the calming technique, hands-on painkillers, getting into the pool, reducing the steps, all the stuff which we talked about. But even at 6 weeks, the quality of life is very, very poor. That is a perfect case where I would say we would think of a single effect. We don't want to be putting multiple steroids, especially in a non-OA hip, but there is no evidence that a one-off injection will lead to long-term issues. So if you look at social media, there'll be a lot of scaremongers on saying like it can cause AVN and rapid onset OA. That's where screening for AVN is important. So if you got an elderly patient, they're more likely to get a complication. So things like sickle cell, things like, radiotherapy. So those groups are a bit different. But usually, if you're a healthy individual, your chances are, you can never say never. It's definitely not even 1%. So that is something to be safe but we don't want to be giving repeated injection. Like a 1 or 2 is generally enough. And that is idea is to give a window, usually around 6 to 12 weeks. And I generally ask them to take it easy for 2 weeks. And then it's like a reset button. The night pain is better. And then it's get them back into the pool, start on phase 1 again, and then build up again. The problem we have with injection is it's hugely variable in the setting. For example, I remember those days when I was 6 or 7, where to get a hip injection, it's a long wait. You have to first get the MRI, then you have to refer to the consultants, and then there's a waiting time. So by the time you have injection, you're talking about 6 months now. And that's totally changed, especially in London. So there's a fantastic lot of private providers in central London where you can get ultrasound injection fairly. You can go in the same day. Always a good idea to get an MRI before you do hip injections, especially in young people. Main reason is to rule out bone stress. Especially most people run here in London. So I don't want to miss out bone stress and put a steroid in. So always a good practice to have an MRI. And then even in the NHS, there are centers, for example, in like where I work in Guy's Hospital, we can do it in one-stop shop. And that is slowly changing across. So I think the accessibility of steroid injection for the right patient is generally opening up. So those are the 2 things which are commonly used. We can go into the other injections shortly. So what do you think of those points, Callum?
Yeah, this is where it's interesting, because here in Australia and New Zealand, physios, I'm going to obviously be biased here being from England, but I think it's fantastic that we have these FCP, APP roles in the UK where physios are able to offer injections. And I think that's part of what's helped speed things up, or certainly make the referral pathway much easier. In Australia, that isn't an option, but thankfully we do have a lot of sports docs on hand that majority, if not all of them, are trained in injections. Something I wanted to pull or pick your brain on here, Benoit, is I had an influx of hip cases last week, all osteoarthritic. 3 of them were FAI that has led to osteoarthritis. That all, 2 out of the 3 of them have already had an injection. And what they said to me in the first consultation, these 2 lads, it was, I had the intra-articular injection under a fluoroscope and it didn't help. Didn't change my symptoms at all. When we pick it apart, we actually found it did change their symptoms, because they're walking better, they're able to sit down for longer, they're sleeping better. these little things that we had to pick apart. And then the light bulb went off and they went, oh, actually, no, it has helped. Now, I've never seen these patients before. They had conservative elsewhere. They went for an injection, then they came to see me, but they were under an impression that it did not help at all. What do you say as someone that's a regular injection therapist? How do you, as we were talking about expectations a few minutes ago, how do you set the scene and manage those expectations where you said, I'm not expecting to inject the hip and all of a sudden 100% pain free. You're looking for 50%. How do you set those expectations before you inject?
Yeah, I think that's a great point. First thing is we need to make it clear what are you trying to do with the injection. So first thing I'm making very clear is the injection is reducing the synovitis and the inflammation around the capsule. So we're not really changing the cartilage. We're not changing the disease process itself, but reducing that, the local inflammation, which is we know is a key pain driver. And we know with the steroids, generally we're talking about 3 to 5 days where it kicks in. So one of the things I always ask my patient to do is keep a pain diary. So simple VAS score especially for the first 2 weeks. So 3 times a day, like the pain score, how much they're working night. So main things, keep a pain diary. And also the first thing I say to them is the biggest effect where you're going to find with the steroid is not on your function, but necessarily on your night pain. So the night pain is where I'm really interested in. So I don't like to inject people with steroid unless they have night pain. For me, that's the main target. If you come to me and say I get pain after 40 minutes of running, I'm not really putting steroid. They made other options like hyaluronic acid, which we'll discuss shortly. But the steroid is mainly that more inflammatory thing. And also the big effect is the sitting time as well. So I'll say to them, can you, sit for longer? But the function will only improve with the rehab. So this is a window to break that inflammatory cycle. The biggest effect you're going to find is in the waking up at night and also the irritability with sitting. And that's it. We can't expect anything more, really. People expect miracles from steroid. It's just breaking that very intense phase. But that is more than enough for physios, to get into and get back into the rehab, So it has, if we look at the studies, we're talking about only a short-term effect from anywhere from 6 to 12 weeks. It's not like massive on that. But we're never going to do this unless we have tried everything first. So they tried your anti-inflammatory, they tried all that. But if you're stuck for 2-3 months, this is sort of the timeline. So, and if it's done through fluoroscopy or ultrasound guided, then the accuracy is more towards 95-98% there. So obviously mistakes can still happen. Sometimes you don't put it into the capsule. So we are all human, even the best injectors sometimes can't put in. That's why if you look at good injectors, they'll always take a picture of, that's what I do at work is when the needle is in the capsule, I'll take a screenshot because the ultrasound can create a freeze. It's always good to check whether actually the needle has been inside the capsule. Otherwise, it's not there. Then it won't work, isn't it? So there's a lot of variables, but we assume that the injection has gone in the right place. But still, it's being very clear on what to expect.
Yeah, and I would say to any physiotherapist anywhere in the world that, like here in Australia, we do not inject as physios in Australia. And I know it's like that across many parts of the world. If you are seeing a patient with any hip-related pain, you've tried rehab, and then you think, I need to send you for an injection, don't get lazy on the screening. That's the other thing. So where, Benoit, you mentioned about screening for AVN, a little bit of self-promotion. I have put this out on my Instagram page if people want to check out a screening tool. But make sure you're screening for it, because I think some of the best physios out there understand the medical side of it, even if you're not the one doing the injection. If you've done the screening and you can put that referral across to someone like yourself, Benoit, or a sports doc, I know that will be really appreciated on the other side. But also just set the expectations so that patients know, listen, you're not going to be 100% pain-free. This doesn't solve everything. The injection will provide us with a reset button, is what you call it.
A window of opportunity, that typically used word, isn't it?
We love that. Window of opportunity. Just to settle things down. And if it settles your pain down by 40, 50%, that's all we're looking for. And set those expectations early so that a patient doesn't go in to someone like yourself, Benoit, get an injection and they expect to walk out a few days later absolutely pain-free, getting back to running. That's not what the injections are there for. So just set those expectations. Yeah.
So another thing is, now moving on, is let's say a patient who doesn't have that night pain, more irritability, they don't want to go for surgery, but they have more like a stiffness point of view. And it's more like the achy feeling, which is extremely uncomfortable. So this is where you have two options here. So this is something, being totally, having a disclaimer here, this is not my area of expertise, but I refer a lot of patients for this cases here. This has to be done by somebody who does a lot of. So we have two options here. One is the hyaluronic acid, So the hyaluronic acid is, it's not reduces inflammation. It's a lubricant. It's a shock absorbers. It improves the mechanical environment of the hip joint. So for people who have that stiffness element and sort of going into the OA, most of the evidence comes from knee OA. So if you look at the hyaluronic acid, most of them comes from definitely from there. And those principles can be used. They tend to work a bit slower, and the effect can be anywhere from 3 to 6 months. And some patients say it's up to 1 year. And unlike steroid injection, it can be repeated. Now, this is where I think the evidence is very different from what actually happens in the real world. So in the real world, I've seen, I don't personally do it, but I've seen very successful cases. People combine the steroid with the hyaluronic acid. So the company will say, don't do it. But that's what I see a lot happen, especially in London. So you got a bit of irritable hip. First, what they do is they put the local anesthetic, and then they put the steroid, and then they put the hyaluronic acid. You throw everything at it, and the idea is the steroid will get a quick pain relief, and then the hyaluronic acid will start working with 3 to 6 months. So there's a lot of variations here. So that's why talking to your local sports doctors or injectors, it's not an exact science, but for people who are desperate for those options, that's a good option here. So hyaluronic acid, same like knee OA, the evidence is variable, but it's safe. So it's not going to cause any adverse effect like the steroid. And then that brings to the last injection option, which will create a lot of debate, because there are some people who believe it works, some people are against it, which is PRP. So the PRP injection, as you know, it's taken from your own body. There's no risk of anaphylactic shock. It has growth factors. The idea is to create a bit of a pro-inflammatory reaction. So I think from a physio point of view, this is 2-3 points. Is when you're referring for PRP, one is they must not be taking any anti-inflammatory. It stops the effect of PRP. So no naproxen, no brufen, things like that. And of all the 3 cases, I find the flare-up is much higher in PRP. Their PRP patients tend to flare up quite badly for 2 to 4 weeks. So again, guidance on them. And this patients I find work, the 2 groups I find work well with the PRP. One is who already have their OA pattern set in, not going for hip arthroscopy. And also the young ones who have more mechanical symptoms and they really have the stiffness there. So I've talked to many experts, and every time I talk to experts on that, people have different views on what's the difference between hyaluronic acid or PRP. But in reality, people use the ladder approach. So people generally will have a steroid, and then you don't want more steroids. And then they might go to the hyaluronic acid because it's cheaper, because most of the time it's determined by the cost. And if that works well, they might have every 6 months, 1 year. And if that fails, they might go to the PRP. So it's not an exact science, but in the podcast which we bring to you, we don't want to just give you purely, we want to show what actually happened in the real world, because we can talk what's best practice, but I'm just saying what I see in London or most of UK. This is the reality, and we can debate till forever that what's evidence based, but that's not the reality of private practice. So it's more like giving patients the choices and guiding them to the people who offer this, especially when they don't want to have surgery.
Yeah, I think that's a good point you've raised there, Benoit. I'm just going to second that, not just with injections, but generally where we talk about research versus real life. I think research is important. Benoit, you and I are always referencing papers when we teach, when we do our Instagram, LinkedIn, whatever else. And it is important. We need to acknowledge that. But something that I will say to whether you're a junior or a senior, read the research, take it in, apply it absolutely. But probably my biggest advice off the back of that, Benoit, is don't take every single thing that you read in a research paper and say, right, this applies to real life. This applies to every hip patient, knee patient, shoulder patient, whatever I see. It's there to inform us. But as you've just said, real life is real life. Research is in a very controlled environment. It has to be to meet ethics and to meet funding guidelines, etc. So just make sure that when you are, was that your phone, Benoit?
Yeah, no, that's true. Yeah, that's fine. Sorry. Yeah, it'll take it. Yeah.
Just make sure that you're using your research to inform your practice. Don't let it dictate your entire practice. Listen to the patient, do what's best for the patient in front of you. And in this case, you're saying if that ends up being a PRP, it ends up being a PRP if everything else has been exhausted.
Yeah. And I think that brings us nicely to the last element, which is surgery. So I think most physios, including myself and the patients, don't want to go surgery because it's not a walk in the park. It's a major surgery. It takes a long time to recover. So we try to delay it as much as possible. But sometimes, so the typical patient will be, let's look at a patient here who is like a young, 31-year-old, 32-year-old male who's got a classical cam morphology, doing rehab well. But every time he goes back, he fails. So goes back to running or football. So this is the typical patient where they have multiple failed rehab. So in a controlled environment, they're fine. When you offload them, are fine, but that's not what they want to live their life on. Nobody wants to stop playing at 31 or 32. So your patients who's, hitting all the markers, but they can't really progress. So who is the ideal patient here? So we're looking at patients who has got a clear pathology confirmed clinically and also radiologically, possibly a good injection response to injection. And also, most important thing is no OA or no dysplasia. So with the surgery we're talking here for FAIS syndrome is hip arthroscopy, where they will do a bit of debridement, reshape the head of femur and also acetabulum, repair the labrum, the soft tissue. In theory, it looks quite simple, but I'd say to them it's the same timelines as you would expect, like ACL. We're talking about 6 to 9 months, more likely 1 year. And the return to running is not in 1 or 2 months. It could be even 6 months. So it's a big commitment here. And the key point here also is the surgical input is hugely important. So ideally, you want to refer them to a high volume surgeon in a high volume center who sees a lot of these cases. Ideally, who have done at least 100 cases there. So they have best outcome. And we tend to see better outcomes in patients whose symptoms are not very chronic, more than 3 years, 3-4 years. By the time, if somebody had it for 5-6 years, more likely to have central sensitization and other issues there. So it's not a contraindication, but their expectation should be very clear. And finally, also the psychological readiness, are they mentally prepared? How is that? We know one of the indicators of poor prognosis is presence of anxiety and depression, especially young people. So if they have more psychological input, so it's not something we discuss straight away. And this is where the MDT is hugely important. Like I know, like you work with few surgeons. I work about 6 or 8 surgeons in the UK. So it's not something you decide on day one. We give the information. They think about it. They've done the rehab, possibly injections. And when you talk about the rehab phases here, maybe we can have it's a huge topic, so we won't have time to go through, but we're talking about the early phase where they'll be on crutches, anywhere like 4 to 6 weeks. And they tend to usually have a flare up, usually by the 3rd month, because they tend to jump on very quickly. They increase the steps and nearly all of them have a flare up. And about 30% of them will need an injection by the 3rd or 4th month to calm it down. So that is quite a common thing. And then get them into the gym. So it's a bit more a slower version of conservative management. It's the same principles, but much, much slower. And the big difference is the crutches and then the soreness. And a lot of people get a bit depressed and upset because it's mentally tiring. So there's a lot of support, family help, counseling. So it's not an easy journey, but in some people, that's the only option if they want to get back to the sport. So it's something which they need to understand, not the physical commitment, but also the psychological commitment.
Yeah, and I think that sort of circles us back to pick your outcome measures that you're going to use to test psychological readiness for surgery. As I say, here in Perth, typically it's the 𝐓𝐡𝐫𝐞 that we use, or the modified Harris hip score. So just pick the one that your surgeons are familiar with, and make sure you're running that test before people are going into surgery, if that's where you're heading. Because I agree, it's a massive physical and psychological commitment. And actually, Binoy, you touched on there saying this is very similar, if not the same, to ACL. I don't feel like that's acknowledged. Well, this is anecdotal. I'm not referencing here. I don't think that's acknowledged very much after a PAO, after arthroscopy. I don't think it's talked about. I think people think, 3 months, we'll be back running, we'll be back jumping. And it's like, okay, we might be heading back into that direction, but this might take 6 months. It might take 12 months, or that 9 to 12 months, like we say with ACLs. And that is worth acknowledging.
Yeah, most of the studies I've seen where they've shown 3-4 months I've been in NFL or high-level professional male in America, in the States. That's not the patient I'm treating. I'm sitting in the average recreational runner. So I'm not treating the NFL guy here. So maybe it's possibly
that's not you. No?
Not really. Maybe they're getting physio 3 times a day and they're the best. They're using Game Ready. They're using all the stuff there. So in the reality, I would say I would push it more towards 9 months, really. 6 months is things are a lot better, but sporting level, you're talking about 9 months, and it could be 1 year as well, especially if they have coexisting conditions like microfracture, if they're on microfracture as well, and they had and if they had a revision, because sometimes many of them fail the hip arthroscopy, because one of the main reasons people fail is incomplete cam resection. So the first surgery, people who are not experienced don't take enough because they're worried that it could cause dysplasia. So they take a little bit and then it fails again. Then they have to do the second surgery, and the second surgery will be much slower than the first. So I think that's where I think the MDT is important, because the surgeon, we should be speaking the same language. If the surgeon says you'll be running in 3 months or 2 months, and you say that he'll be running in 9 months, 6 months, it's not going to go well, isn't it? So it's really important to have that honesty, isn't it? So I think working with surgeons who share the similar philosophy, also realistic. Obviously, see, I don't have any problem getting them running in 2 months if I can. I don't get any joy in stopping them. But the reality is it doesn't happen. I never see it happen, really. So sometimes people look on online and say, go to ChatGPT and say you'll be running in 3 months. I would say take it with a pinch of salt, because that is more a rosy version of that.
Yeah, look, it's like you said earlier, people, it's human nature. As soon as they start to get a little bit better after that 4-6 week mark, whatever, they'll start ramping up their steps. They'll start trialing things as well. I also think that sometimes physios, as you said, Benoit, we can put pressure on ourselves, and that if we haven't got someone back running within 3 months, we feel like we're doing a crappy job, and we think, oh, let's just get running. Do the basics really, really well. If they're not running after 8 weeks, they're not running after 8 weeks. It's not time bound. It's objective testing bound, isn't it? All the same stuff we say in the ACL world, the same applies to the hip.
Yeah, definitely. The last point I would say is try to keep it more on benchmark. They know exactly each phase what to achieve for, strength phase, plyometric phase. So it's not a guess, work with data. People know what to expect for. Especially, I think I'm very, very strict. I think there are 2-3 points where I think things go wrong here. One is when they come off the crutches, they start working a lot. So they make a big, when your crutches, generally you can't walk more than 4,000 or 6,000. When they're off the crutches, they go to 10, 12 or 14,000 steps. So that's a big problem, I find. That's number one. The second thing is rushing them into return to running. I think return to running is because you're jumping 3 times the impact forces here. So I'm very, very strict on return to running. Is very clear markers on strength, usually 2 to 4 weeks of plyometric phase, and a very conservative, boring walk jog program, usually twice a week, and then build up. So I'm very, very cautious on the return to running, because this is not like a simple tendon rehab where you can be a little bit more aggressive. So those 2 phases you have to be very cautious on when they're off crutches and when they go back to running. And maybe the third phase is equally important when they go back to rotational sports like hockey. So straight line running is very different from hockey. So you'll have to have very clear criteria. So I think those are the possibly three important tipping points there, where you need to keep a very close eye on them.
I think you've just set the scene for a different episode there, Benoit. Return to sport testing. Because I know that you'll have we're very similar. I know you'll have slight nuances. I'll have slight nuances. Maybe that is something that we can, if people are interested.
We can look into.
Yeah, maybe that's a future episode.
Yeah, definitely we can. So I think those are the key points. So keeping on timeline. So what would you say some of the key take-homes would be for our audience from what we covered?
I mean, what I would... Well, I'll summarize, Benoit. You tell me if I missed anything. I think the first thing we spoke a lot about was managing expectations, conservative management, injections as what to expect, as well as with surgery. Setting the scene, managing those expectations, and setting realistic timeframes as well. If you're doing conservative, you're going for at least 3 months. You went through your sort of protocol that you're advising people after injections as a stepped approach, also a stepped approach towards surgery. You went through sort of the phases of conservative management, and you've put here, the first one is just to set irritation. That could be anywhere from 1 week, 4 weeks, 6 weeks. Then anywhere up to 12 weeks after that, you're building that strength, you're building that volume, etc. And your phase 3 is your return to sport sort of parameters. They were your 3 phases for conservative management. If all of that fails, that's okay. It happens. Don't beat yourself up about it. But that's when we've got injections. And you said, Benoit, it's a bit of a ladder approach where we go through the steroid route. Make sure you're screening for things like bone stress, AVN, things like that. Make sure a steroid is appropriate. Then it's hyaluronic acid. Then it's PRP if indicated, and lean on people like yourself, Benoit, that do this, as well as the sports docs as well. And we had sort of post-injection protocols that you follow. And the first bit, as you said, they just need to rest, whether that's putting cold compress on, pools, baths. I mean, just on that point, you don't want to have get into a pool or have a bath too soon after injection. You probably want to allow a few days. Low impact activity, slowly over that first 1 month post injection, up to 3 months post, you're building that strength again, and it builds up that way. Surgery, arthroscopy for FAI, providing there's no dysplasia, providing there's no significant osteoarthritic changes, arthroscopy is a good option. And process for timeframes after surgery could be 6 months, could be 12 months, really depends on what they're trying to get back to doing. That's, I think, everything that we've covered in today's episode.
Yeah, definitely.
You tell me if I've skipped past anything there.
Yeah. And the thing is, sometimes I used to have that mindset where I was not really interested if it was not just a physio thing. And I think we have to look beyond physio side of things. Here is patients are more knowledgeable. They look up online. We got all these AI resources. People are not going to just look at physio stuff. They're going to look up and they say, people will always ask me, will injection help me? Do you think I need surgery? Who is the best surgeon? You know, how long it take? You know, people are going to bombard you with these questions. You can't just say you are here just for physio. You can't just say that anymore. You know, you need to really be aware of the bigger landscape. Although you might not be doing any of those things, you need to show your depth of knowledge here. And also the patient can understand that they're with somebody who understands that 30,000 view of FA syndrome, and it's just not exercises or education alone. And also they know that you will refer them in the right places when there is a need. So I never say that I'm never going to refer you on. If, you know, I'll say, let's try this. If things don't improve, I got all the best guys in town. I know who to go for these injections. One of the things I pride myself is the network. You know, I try to see myself as a part of a team here, and that's especially for any young or a new grad who want to specialize in hips. Is you're only as good as your group you work with. So even if you're a lone worker, try to build up your networks. Go on, like even I was saying to Callum, like last week, I was sitting at UCL, spending a couple of hours with some of the top hip surgeons, learning about hip resurfacing, building up my network so that I can refer my right patient. So it's my best interest that I know the top guys in the country so that I can use their help. And my rehab also becomes much more easier. So I think it's all about learning from each other. And I think these patients, in my opinion, can't be managed on your own. You know, they need a team. And doesn't mean like we are working in the same building, but we are all connected, you know, especially with social media, you know, internet. We can just say like, you know, can I get a second opinion for my patients? And most surgeons are more than happy to. And one of the things that talk, like I work with Christian Smith, who's one of the surgeon, and he says, sometimes you just want an opinion. You're not sending him for surgery. You're just sending them to check if there are things missing. Referring for surgical opinion doesn't mean surgery. So try to build up that network, and that sort of will be helpful for everyone. You know, so that finishes our episode. Any last points before we wrap up?
My last point there, Benoit, is just to echo you, like I always do. Don't be the superhero. I'm gonna shout him out, Liam Chong. If he's listening, Mr. Liam Chong, good friend and colleague of mine. Benoit knows him as well. If you're listening, Liam, I'm quoting you, my friend, because he always used to say when I used to work with him, don't be the superhero. And that is just what you've said there, Benoit. I have it at my job now. I'm so fortunate to have a women's health team of physios. We've got 4 or 5 of them. I lead on them. They lean on me. We refer out to sports docs and surgeons. Don't be the superhero. Work as part of a team. That's what the best physios do.
Yeah, brilliant. Thank you guys. So follow us. Yeah, thanks. So follow us on social media. We'll be putting links to the free booklets, and also we got quite a few courses coming up. So I'm doing Holland. Then we might be repeating one in Manchester as well. So if you're interested in what we're doing, also you also change your workplace, isn't it? Like Callum, do you want to know where people are where you're working now? If they want to drop down, fly down to Perth.
Just so everyone's aware, Benoit hasn't invited me to Holland with him at all. I'm still a bit upset with him about this, but no.
Yeah.
I'm in Perth, so anyone that wants to find me, Promotion Health in Claremont in Perth, Western Australia. I'm quite far afield from Benoit now, hence why he doesn't invite me to anything. But if anyone wants to find me, that is where I'm based. So LinkedIn, Instagram as well, you'll find me.
And my private work is Your Health in Baker Street. So if you got any queries of patients, I'll be happy to help you out. Thank you, guys. Looking forward to the next episode.
Cheers, guys.
Yeah, thanks.